Hello, and welcome to today's webinar, Roadmap for a Return on Productivity, the second in a series of webinars presented by Lehigh Valley Health Network, Emergenuity, and T-System. Today's webinar will outline how to implement simple solutions that will provide immediate relief and measurable improvements to your ED. My name is Amy Johnson, and in just a moment we'll be joined by our presenters. If you have any questions that you would like to submit for the question and answer period at the end of the webinar, click on the icon with the question mark and type in your question. You can do so at any time throughout the webinar. We will gather these questions and try to address as many as time permits at the end of the session. If we don't get to your question, we will follow up with an email to you one-on-one. We will have a recorded version of this session in the event that you want to go back and review the material, or if you want to share the presentation with a colleague who isn't able to attend. I will distribute the recording to all attendees. Leading our presentation today are Dr. Richard MacKenzie and Dr. David Richardson, practicing ED physicians from Lehigh Valley Health Network. Dr. Richard MacKenzie is an innovative physician executive experienced in turnaround and management of emergency and ambulatory medicine with multiple sites in university and community settings. He currently co-leads the steering team implementing a unique intake team model for emergency care delivery at the Lehigh Muhlenberg site. Dr. David Richardson has worked in the Lehigh Valley Health Network as an emergency physician since 1995. He is currently the Vice Chair Quality, Department of Emergency Medicine, and Chair of the Department of Emergency Medicine PI/QA Committee. We also have a support panel who will assist with the QA at the conclusion of the webinar. Dr. John Weary and Chris Kidda of Lehigh Valley, and Dr. Todd Warden of Emergenuity. And now to kick off our presentation, here's Dr. MacKenzie and Dr. Richardson.
Hey, Rick, it's good to be here with you again. As you know, during our last webinar, we talked about the need for change. This webinar will focus on making it work. We will spend some time talking about different processes that improve efficiency in the input segment of patient flow through your ED. In the third webinar, we will talk about how to make changes last and the people, process, and physical space needed to sustain your improvements. So let's recap quickly what we talked about at the last webinar. All right, so let's make it real, Rick. We talked about left without being seen rates and how those two things, left without being seen rates and diversion hours, reduce your revenue. And during the last webinar, we used an example of a 40,000 visit ED and how it was able to reduce its left without being seen rate from 6% to 2%, and reduce diversion hours by 400. Capturing this patient volume could increase charges by over $3.2 million in a year. Patients who wait are more likely to sue. High ED crowding is associated with higher mortality for patients admitted during the time of ED crowding. And the longer patient waits, the lower their patient satisfaction scores are. So there is a need for change.
Well, let's make it real. We're going to make it, we've made it real, now let's make it work. And you can see, there's hope. The sign says it right there.
Well, Rick, I remember that too, and I think you need to mention here that we have to have faith, courage, and persistence too.
Keep your knickers in a twist. We'll get to it.
All right, I will. What's up next, Rick?
So one of the things is, you can see we're going to talk about input, throughput, output, and sustainability. There's so much hope out there that actually we have two webinars dedicated to it. We're going to talk about input today, and then we'll talk about throughput, output, and sustainability on the next webinar. We're going to go forward with this, and we'll talk about input.
So, Rick, this is my favorite slide, and the reason why is because of this first bullet, influence and control. The emergency department front door, and I'm going to put the front door in quotes here, more than any other place, is directly under our influence and control. We have more influence and control over the input side of the ED than anywhere else. We can directly affect the processes, policies, and behaviors related to getting patients into the treatment area. Remember, most EDs treat and release patients. Most of those patients, they don't get admitted, they go home. So get them in, get them out. Now, things like diagnostic test turnaround time, consultant response time, inpatient bed management, it's under our influence a little bit, but really not under our control. So I get the impression that changing the front door of the ED is easier than changing the back door to the inpatient realm. Now, patient satisfaction surveys ask questions like, how long did you wait to see the doctor? And how long were you waiting in the waiting room before somebody even noticed you? So processes dramatically reduce the time the patient waits from arrival to when they're noticed or arrival to when the doctor sees them is what all input is all about. So remember also, door to EKG, door to pain management, door to provider is how ED input will be measured via core measures.
So this is a good graphic when we start talking about the input side of things. These are kind of variations on the input aspects that we'll talk about in more detail, but you can kind of see it as an evolutionary diagram, kind of like the core being the full to full. So if you want to think about it, if you've not done anything with your front door, think of moving in concentric rings outside. So let's talk a little bit about traditional triage. Traditional triage, and you need to understand this to understand our front door better. It comes from that French word trier. Basically, this really was about sorting. That's what it meant. And its origin back in the heydays of emergency medicine, which I unfortunately can remember, the sorting was, we had plenty of beds. It was just a question of which bed the patient should go in. Do they go into the OB-GYN bed? Do they go to the orthopedic bed? Do they go to the pediatric bed? And in some places, actually, it meant different doctors, whether we were talking a medicine department or surgical or surgery emergency department. So actually, the sorting had a purpose to match the patient to the right bed. Now we're in the mode where the sorting is trying to make up for insufficient resources. So we're now prioritizing the sickest patient. And the difficulty is those resources are dynamic in terms of what we have. So as the resources become more insufficient, you pick the most sick out of the people in the waiting room. And do we know the least of those sick patients, do they really need to be seen faster? So therefore, triage is really equals who actually waits. Is it the really sick patient, the not so sick patient? And on top of that, in the wise move of our government and other regulatory agencies, they figured out that patients wait a lot in the emergency department, so why don't we just throw a whole bunch of other questions on that waiting time? And in fact, in the Journal of Emergency Nursing, there was an article on ED triage where they measured the need for triage to occur every 3 minutes, and yet it occurs in 9 minutes. So triple the time it's needed to actually get the triage done because of the regulatory burden. So this is something we really do have to address. So next, I'll ask people to suspend their disbelief at this point, but I'm challenging all of us to think about this. Are we truly just managing our demand down? And when I say demand, we talk about demand and capacity. So there's a demand and capacity mismatch. Demand is the number of patients seeking care. Capacity, in a somewhat simplistic way, is you can really define it as people, process, and physical space. And these three things have to exist in an equilibrium. You cannot change one without actually affecting the others. So you really have to pay attention to all three. We get into the fourth P when we start about planning. So if your planning or your purpose is to meet the demand on a yearly basis, you're going to have times of the year and times of the day where your average demand will exceed your capacity. And we'll show a little bit of that later in the presentation. If you meet hourly an average demand, that might have some benefit. In fact, there was a recent article in the Society of Acute Emergency Medicine that talked about hourly demand and the volatility there and how that relates to our processes. But the bottom line is there's a belief that the patient can wait, and especially that patient that doesn't need to come to the emergency department. What we do is we create a fixed cost, limited capacity system. Good news, it's fixed cost. It doesn't have variation in cost, but it's a limited capacity system, and that's why we're in some difficulty now. And we have to manage demand down if we're going to have that fixed cost, limited capacity system. So let's talk about input. The input You have multiple things here. I'll talk about each one of them in detail, in a little more detail. Bedside registration, pull to full, fast track, vertical flow, super track, intake treatment team, and I will hit one more that's not on this slide, and that's what I would call protocol nurse testing in the waiting room. So the protocol nurse testing is the aspect where a nurse is driven by a protocol to draw some labs, do EKGs, do CTs, do x-rays, whatever they need to do, but it's driven by protocol on people waiting in the waiting room. It does speed your testing aspects on that, but that exists in any one of these models that we're going to present here. So bedside registration.
Rick, I like that sign there, the one way. I think I saw that in your living room. I think that's where I took a picture of that sign. I think your wife put that up. Let me talk. I got the quote for the day for you. Here it is. Processes that run only 10% of the day are very difficult to sustain. Processes that run 90% of the time are more easily sustainable. So that's my quote of the day as we talk about bedside registration. And if you look at any manuals on recommended processes for ED efficiency, bedside registration is one of them. And it's an important step in the emergency department because it's directly related to creating an account for hospital information systems, including documentation and order entry. And studies have shown an initial decrease in triage to bed placement when you implement bedside registration. Most of the articles noted there was a capital cost related to implementation, and so it costs money to implement bedside registration. And also, bedside registration was associated or combined with an immediate bedding process in the ED. So bedside registration results in decrease in triage to bedtime when beds are available. So I'm going to reiterate, you have to have beds available for this process to work. And Takakawa noted in a study from Thomas Jefferson University that sustainability of early gains and length of stay reduction was difficult because of the lack of staff buy-in, cultural resistance, and lack of incentives associated with these change management initiatives. The bottom line is, you may see an initial reduction in triage to room times when you combine immediate bedding with bedside registration. And there's a big and in here. The and is if you have open beds. So Rick, the million-dollar question is how do you keep beds open?
So keeping beds open is really, you hit the nail on the head. Each one of these models really relates to what your bed capacity is, because these are process models. Remember, people process in physical space. So if you have capacity on the physical space side, you can implement many of these models, and they will improve your process and your speed through the system. So it's an analysis of your own individual, and I'm talking to the entire audience here, it's an analysis of your own individual site and what your capacity is on any one of those things. So let's talk about pull to full. Pull to full is basically the patient arrives in the emergency department and they get pulled right into an inpatient bed because there's an inpatient bed available. This may sound kind of easy, but there's a lot of barriers to implementation in terms of the chart following the patient, being ready for the patient, vital signs being done, assessments being done, and it really should be attacked in a kind of a process in the sense of an implementation process. You need to implement it with specific guidelines and on specific days. This is not something you put out on a PowerPoint and actually get it out there and actually expect it to work. So the next one, enhanced triage. Now I mentioned these because these are all kind of different forms of triage. While the nurse testing triage is one form of enhancement, these are different forms of doing triage. And there are some sites here that actually have these up and running. So the provider in triage is the provider sitting within earshot of the triage nurse and will peel off anybody that is what would we call an ESI 5, somebody who really needs nothing, and you can get them out immediately. So they're going to listen in, pull off those, and then help in the triage decisions that the triage nurse may help. So the two-track triage, that is in Banner Health. It's actually written up as an AHRQ document, and you can go into ahrq.com and find this. And it's a two-track triage. They ask 4 simple questions at triage, and then the patient is determined whether they go to a fast track or express care versus the main department. So it's speeding the triage process to get them into various areas. There's also SuperTrack, which is in Mary Washington, and they actually have a separate area where they have, it's kind of like an express care immediately behind triage, and they try and peel off everybody that they can. It's a little bit more in-depth than the provider in triage, so they actually do some testing and get some simple patients out. MidTrack is a unique one in the sense that they actually use ESI 3s in this section. So they've made the point that they have an express care for the ESI 4s and 5s. The MidTrack is really those ESI 3s that sometimes choke our system. And again, what you have to analyze in your particular model in our audience is what is choking up your system. Is it the really low acuity? Is it the ESI 3s? Are you really seeing a high acuity population? So you really do need to know that. Then there's also team triage, where University of Maryland has 4 beds, and they'll team triage a certain portion of the day and actually deliver that patient to internal waiting areas, which I'll get into in just a minute, in various areas of the department relative to different pods in the department.
All right, Rick, let me talk a little bit about express care. And express cares have been around a long time, and emergency departments have developed certain areas to treat patients with non-acute illnesses. So you get express care, quick check, fast tracks, or several other brand names out there. These express care areas are for patients that require few resources, basically your ESI 4s and 5s. The successful express care standardizes the operational and clinical approach to the non-acute illness patient and becomes a way to treat up to 40% of your patients and improve flow. Make sure that you have matched the hours of operation with patient demand and that you have the correct combination of people, process, physical space to give you the highest return on productivities. Studies of fast track show that there is a reduction in length of stay for those ESI 4 and 5 patients. Fast track is usually a separate area of the ED with separate staffing, skill levels, supply and storage needs. Patients usually are triaged to fast track, so they still need triage, and sometimes patients are sicker than originally thought, so they have to then be moved back to the regular ED. Some fast tracks have their own waiting area, which can be an inefficient use of space. And also, the natural variability in patient acuity may result in overutilization or underutilization. So fast track is getting hammered and the main ED is empty, and you've seen this before if you have a fast track. And from a patient viewpoint, there are some non-value added steps to get to fast track. You're asked the same questions multiple times by multiple ED staff. So Rick, do you like being asked the same questions over and over? So Rick, do you like being asked the same questions over and over? Hey, Rick, do you like being asked the same questions over and over?
Stop. No, I don't like that. So we're going to talk, remember I spoke about that internal waiting areas at the University of Maryland? This is vertical flow, and this is very efficient for your space. So if you're limited on physical space, think about vertical flow. If you have a large room in your emergency department, you might turn it into a vertical flow room or results waiting area. And what you do is, the basic principle is patients come in and there's a little clue. When they come in, they sit on a stretcher and sit. They don't lie down, they're sitting there, or they're sitting in the chair beside the stretcher. Those people want to remain vertical and they don't need to take up the space, the 110 square foot that a room will occupy. So you turn that 110 square foot into about a 4-foot square area, definitely a return on productivity of your space. So if you're limited in space, this is an idea. So I'm getting to the stuff that we really like here, and this is at Lehigh Valley Muhlenberg. We've implemented a rapid assessment unit, and this is kind of like the graphical representation, perhaps, of what we did. And really, if you're thinking that, and you think of lean, and that's what we are, kind of a lean institution, we want to remove 3 steps. And the more steps you remove, and we've removed 3 steps in the process to arrive at our future state. You can study this later when you see the next slides. So we're going to talk further about this in the rapid assessment.
So Rick, you're telling me that you don't need triage? No way, man.
Yeah, no, way. No way. You know, we have no triage and no express care. That's an amazing concept. So this is the intake treatment team. No waiting for treatment is the goal. It is kind of like the mass casualty model. You begin your treatment right away. You manage all that weight waste. people don't realize, a lot of you triage nurses that are probably, anybody that's been a triage nurse knows the expense of managing the wait. How many times the patient comes up to you and asks you the same question, how long is it going to be, how long is it going to be, how long is it going to be? Those kind of things are managing wait, and they take time. Triage nurses also know the hourly volatility of the emergency department, and that's a big factor, and they're stressed by that. They are the funnel that gets people to the back. So in a sense, this intake treatment team is a solution for the stress that a triage nurse may feel. The efficiency is really clear in this intake treatment team, and let me just explain that one aspect, is that this is a team of nurse, physician, and even registration at the bedside hearing the patient tell the story once. So that's the important part of it. They listen in. The doc waits for the nurse to get their story. Interesting kind of sidelight that I found out when we implemented this, that the story the nurse gets is usually the best story. They go on and talk, and that's ironic since the nurse just wants a chief complaint. So they get the best story, and if you're in a teaching institution like we are, and I'm the fifth in line, I get the worst story. I get the most brief story. So if we can get it at the front door, tell it once, the patient feels valued, and actually we get a better quality out of the whole thing, and it's far more efficient because we get it all at the same time. So the RU goals, and essentially these are goals, we've evolved them over the course of time, but essentially these were the goals when we first started. Vertical patients remain vertical. We want to keep that door to doctor less than 20 minutes. Patients spend less than 1 hour in an RU exam room. They get moved to either a vertical waiting room or a vertical flow waiting room, or they get moved to the acute care from there if they need to, or they get discharged directly from the RU. So that's where we take care of the express care patients. Essentially, this rapid assessment unit physician is responsible for express care and moving them around. We also have PAs in our RU as well. And finally, we want to practice any kind of situational decision-making. We actually have an escalation protocol or dynamic variation we'll get into in a minute that helps with that situational decision-making. So next slide. We have this is I would say, the money slide. This is the choice slide that we were trying to do. So do you want the RU or do you want traditional? There are benefits and not so benefit of each. The big one is the traditional is staff-centered. Having that triage nurse as the front guard of the waiting room and metering those patients in slowly into the rest of the department really makes the staff manage their flow better. It's a more predictable flow. It prevents that volatility. The RU is patient-centered. In other words, you move the traditional at the speed of available capacity. So if you don't have the capacity, they wait in the waiting room. The RAU moves at the speed of the patient demand. You feel that hourly volatility. The triage nurses may have felt it all along, the physicians have not. So this is a downside of sorts. You're going to have to deal with physicians suddenly being aware of the hourly volatility. And it's not necessarily a pleasant experience. So we're going to talk about dynamic variation. This is one of the things that we discovered in this model. The good news is if you set up for an intake team, you can vary to all those other ones on that little concentric circle diagram that we had. You can work backwards and actually, like on tumblers on a lock, if you have understand what your demand is, understand what your capacity is, understand where your dispositions are going, you can actually employ all of those front door variations. And we have a dynamic variation protocol that we actually use. And it looks like this. I know that looks scary. And the guy who made it is kind of like Frankenstein is his name. He actually made this thing. But it isn't as scary as it looks. This is like the play card for the Super Bowl coaches. Each one of those lines might represent a task for one team member to do. So it's not as scary as it may seem. It actually helps us do our tasks. And it's play calling, essentially. When we get to a certain level of demand, then the team moves in a different direction. So what are our results? How did we do? with this? Well, this is an example of the difficulty of averages. One of the things you'll find with enhanced triage, or any of the steps you have there, you will decrease your average length of stay. There's no question about it. If you keep the traditional, you will have that top curve kind of approach. You will have a variation in length of stay. We only decreased by 35 minutes on average, but if you look at 2 p.m., that's the middle bar there, we decreased by more than half. The patient was waiting over 72 minutes on average at that time, and I consider that very unacceptable, and that would include our sick players. But you can see there that we really kept it down, and you can see far less variation across the clock. So did we treat our sick players faster? That's good. So we did an analysis. We did ESI2 admits that walk in and wait greater than 30 minutes. So we kind of looked at November in our Muhlenberg site, and we had 64 patients that waited greater than 30 minutes. Realized our average length of stay at that point was in the 60-minute range. 64 patients, and we had about a 2% left without being seen. We had 64 patients, 19 chest pains, 5 CHF, 1 PE, and 1 in STEMI that waited greater than 30 minutes. And I think we all can feel like that's a little bit of a risk. Perhaps they could wait maybe 35 minutes, but I really would like to see them sooner. Next slide, or next bullet here. We see that we have Cedar Crest site. This is a bigger site that we compared. We don't have the RU implemented there yet, but you can see at a bigger site, this is 77,000 visit emergency department. You see 164 patients, 24 chest pains, 5 CHF, 5 PEs, 3 in STEMI, sitting in the waiting room greater than 30 minutes. And finally, we looked at January LVHM. Literally, we had 4 patients total. Only 1 was a chest pain, and that chest pain was really chest wall pain. So I think we are meeting our goal of getting those sickest patients treated faster.
And Rick, and the patients are happy about it. So we looked at our patient satisfaction scores, and just like everybody that's listening, we have a passion for improving patient satisfaction and communication. And again, Press Ganey ED surveys have several different sections, including arrival, nurses, physicians, tests. And so let me tell you about this graph and what it represents. If you look at the vertical axis on the left, that is the overall rating of ED care. That's the mean score. The horizontal axis is from January 2011 to December 2012. And you see something good happened in December of 2011. We jumped up to the 99th percentile in overall ED rating of care. And so that was a phenomenal good thing that we saw. So the patients appreciated getting in to see the physician first or as soon as possible. And really what we saw was the arrival section from our Press Ganey surveys went to the 99th percentile. And then there was this halo effect. So we saw a huge increase in overall rating of ED care. And this is the kicker. We also saw an improvement in our HCAP scores for our inpatients. So the patients who ended up being admitted through the rapid assessment unit and ended up going in the hospital, they had a better experience because of what happened at the front door, and we saw that reflected in the scores for HCAPs.
So it's a choice, and we're talking about a choice. Do we want a crowded emergency department, or do we not want a crowded emergency department? Now, this is not, I'm not to say that if you just do input variation, you're going to get the non-crowded emergency department. That is actually our emergency department at 3 p.m. in the afternoon on the right. That's our waiting room. So I'm not going to say that everybody will experience this, and in fact, I want you to make a choice based off of what you see your needs are. Do not try and fit a square peg in a round hole. So we've talked about input, influence, control, and choice. These are all things you need to really think about as you think about the front door. We're going to talk further about throughput, output in the next webinar, and we'll talk about sustainability. But keep these principles in mind as you attack this issue of crowding. And we're ready for questions. So, Ann, are you there?
All right, guys. Yep, I'm here.
Okay.
So the first question is, what is the hardest part of this solution? How do you get people to maintain focus and sustain the process?
This is Frankenstein here.
That's the guy who wrote that chart.
It really starts with staff engagement. Well before we changed the process, we did tabletop simulations that really served as education and training sessions, and just getting all the input from all staff, clinical, non-clinical staff, in terms of, there is a change coming, and what does it look like? We knew the overall goals. Dr. MacKenzie went through the guiding principles of the RAU. We knew that. So what does it look like? What are the process pieces we need to make that happen? And getting that staff engagement early on was probably the biggest success factor in sustaining this once we opened.
So, and again, the hardest part is the people part, and you want to give them a simple goal that they understand, or simple goals, whether it's 4 goals or 1 goal, and you want to make the worst change anybody can experience is sudden and severe, so you make it less sudden or gradual and less severe. So if you get those 2 principles in mind, it will stick.
And then just one short piece to add on to that is the leadership commitment. Early on, the message from senior leadership was very clear that change is coming. We know kind of what it's going to look like. We're not exactly sure, but it's not going away. We will change, and they held firm, and that message was clear throughout the whole change process. And I think that's a big player in this as well.
All right.
Okay. The next question is, when do you have to use triage in the RAU?
That's a good question. It goes in that escalation protocol. If we got all beds full in the RAU and all beds full in the back, and this happens only really when we have a backdoor issue and we can't get people upstairs, if we get all beds full in the RAU, then we will have to use triage. And we escalate to that. We actually have a process where we actually can move it to a traditional, we can move all the way to a traditional emergency department if we have to. It happens rarely.
Okay. We have a couple more questions. Can you discuss physician staffing for the RAU model? Are there dedicated providers for the initial eval and other providers in the main ED processing patients? Did we read that again?
Yeah, no, it's Dave Richardson. I'll answer that one. And so the Rapid Assessment Unit is staffed by both APCs, which are mostly PAs in our model, and physicians. We also we have a residency, so we have a procedure resident whose job is to do procedures on those patients that are lower acuity. So the ESI 4s and 5s, they will help out with procedures, and it gets them the number of procedures they need. So the process is whoever's up next is seen by the team. So when a patient is walked into one of our rapid assessment empty rooms, the team goes into the room and sees the patient. That may be whoever's up next. It may be a physician. It may be an APC who sees that patient next. And if that patient requires a higher level of care, which we have defined what that is, and everybody knows what that definition is, that patient goes to our acute care side where care is taken over by a physician and resident team. The goal of that rapid assessment team is to assess the patient, what type of testing and medical care they need, and then put the orders in for that testing. And then if that patient needs acute care, they're moved to our acute care side where a physician resident team take over care. And there's a communication process that goes along with that.
So yeah, it's John Wary. I'm the site director at Muhlenberg. To further clarify the answer, there is always a physician in the RAU and who stays in the RAU, and the role is to make decisions. You evaluate patients with the team, decide is this somebody who can be treated and discharged, can they be treated and be managed within a 2 to 4 hour period. In those cases, we utilize protocols. And then thirdly, is this a patient who requires a more extensive workup and may have a high likelihood of being admitted to the hospital. Those patients go to the acute care side. In the acute care side, that actually looks like the traditional emergency room. All the ambulances will go right to the acute care side directly. patients from the REU are handed off to the acute care physicians. So working in the REU is actually, it's a somewhat different skill set, and having doing it for a little over a year, I can tell you it's really, like I said, a different skill set and some different decision making and breaking of some old habits in comparison to what we think of as traditional management of the emergency room. So the one thing I think that everyone finds very gratifying about being in the REU is that when you have, say, 10 patients that need to be seen and treated and dispositioned, you can actually go through those patients in a very rapid fashion. It's not like you're looking at the waiting room board saying, wow, there's 10 people out in the waiting room waiting to be seen. When are we going to get to them? The patients are right there, and you can get to them quickly, make rapid evaluations and quick decisions, and manage that volume very effectively and very efficiently. And by the way, patients love it. Every day people ask me where they can write letters to compliment the staff. So a very big, very significant change from what you think of the traditional emergency department model.
And I'll just add in, just to answer a little bit more specifically, we have, at peak times, we will have 5 providers in the REU, and we'll have 2 providers in the back, along with some residents in the back. We don't have many residents in the front except that procedure resident, and we find that that works the best. We also find that as opposed to the traditional flow, you throw providers in the back of a traditional emergency department, they really don't speed things up. In the REU, we add providers, we see a speed up. So it's definitely value added. And again, recognize that our choice, and we had a choice just like everybody does, and our choice was we could build a 25-bed extension to our emergency department with all the process and people changes that would entail. So on a one level, this is probably people neutral, process very efficient, and also space very efficient. So think of it that way. So people neutral if you've been out, so you build out. And one other thing I will talk about in our implementation, we did do some up-staffing in the initial implementation, and we also had to do a lot of leader coaching and online coaching to make it stick. And we'll talk more about that when we get into sustainability in the next webinar.
Okay, we have another question. Many factors contribute to ER crowding. How do we ensure we are not just shifting our bottlenecks to other departments?
That's a great question and absolutely true. What you do is a whack-a-mole game. You hit one whack-a-mole and another one will pop up. But unless you start somewhere, you won't know where the next bottleneck truly is. And in fact, we're working on our backdoor situation as we speak right now to try and improve that flow. And because it has popped up as a problem as we're going through. Not in 2 modes. One, the literal process of getting an admitted patient upstairs, and the other mode, which is some bed availability, physical bed availability upstairs, and that goes back to inpatient length of stay as well. So, yes, that's absolutely true, and what you do is you say, I'm committed to doing the next bottleneck.
This is Todd, and one of the things that we found is that when you eliminate triage and then sequentially eliminate the bottlenecks, within your own operation, you have a tendency then to push the bottlenecks further and further away from the emergency department proper. And by the time, and I think you've seen this, Rick and David, by the time you get done, it really highlights where the external bottlenecks are coming from, like the performance of the hospitalist or lack of beds on the floor, and it then allows you to really focus your resources on fixing those once you've eliminated all the internal bottlenecks sequentially.
All right, next question.
All right, guys, we have one more question. When you mentioned interesting input ideas. Any suggestions for quick wins to create the momentum for a broader ER transformation?
Yeah, anything. Do something. there's a, go ahead, you can answer that.
And my recommendation would be really, two of the most common things would be the pull to full, because you don't have to change a whole lot of process, or you don't have to change physical plan. You still have a triage nurse who, when the patient arrives, you have a bed in your ED proper, you can just bring them into that bed. But again, you have to change process and do the education related to that. So that's one that's pretty straightforward, doesn't require a lot of physical plan changes. And then the second, which requires physical plan changes, would be that express care, where you can pull off 4s and 5s and manage those efficiently because of the limited resources that are needed to treat those patients.
Yeah, I think one of the things that I just heard, and this may be a complete paraphrase, but apparently George Patton gave a quote that a plan violently executed on time is better than a perfectly executed plan a day late. So the point being is try and start doing something. Those are where your quick wins will happen, because people will start seeing the needle move, and that's what you want to do.
All right, before we wrap up here, there's one last request we want to make to everyone. If you have any questions about anything that's gone on in the series so far, or anything that you would like to have answered in the next presentation, please feel free to send us questions, other questions that you may have. You can either send it to the link that you have, or I'm sorry, right now while you're on this call, you're still connected, or you can send them to Beatty, A as in Apple, B-A-T-Y @tsystem.com.
All right. Thank you. Thank you, everybody.
This concludes today's webinar. On behalf of Lehigh Valley Health Network, Emergenuity, and T-System, thank you so much for joining us, and we look forward to having you for the final webinar of the series on Thursday, February 14th. And we'll have registration information included in the email that we send out to you guys tomorrow with today's recording, so you can register for the third webinar when we send all that information out. Thank you. So thank you guys so much.
Thank you. Thank you.